So today we will talk about the platelet aggregation system. So whenever there is a damage to the endothelium of the blood vessel, that damaged part must be plugged with something so that there is no excessive bleeding. So this is done by a platelet aggregation system along with the coagulation system. But the platelet aggregation system first plug the leaked area loosely. After that, the coagulation system will strengthen this platelet aggregation system so that bleeding is completely stopped. So what really happens is that we can divide the platelet aggregation system or aggregation of platelet at the damaged area into 5 steps. The first step is known as adhesion. So whenever the blood vessels are damaged, the exposed subendothelial collagen and the von Willebrand factor binds to specific receptor on the surface of the platelets. So what really happens? That endothelium, which is adjacent to the damaged endothelium, will release a factor which is known as von Willebrand factor. The von Willebrand factor will binds to this subendothelial collagen, mainly at a site where the endothelium is damaged. Once von Willebrand factor is bound to subendothelial collagen, it then binds to platelet via a receptor known as glycoprotein 1b receptor. So this leads to adhesion of platelet to the damaged area. So this is the adhesion step. The second step is the activation of the platelet. So once the platelet is bound to the endothelium via glycoprotein 1b receptor, it results in the activation of the platelets. The activation of the platelets leads to release of various platelet granules. In the platelet, there are several granules which contains multiple substances such as ADP, thromboxane A2, and serotonin. So once the platelet is activated, it will release granules which will contain adenosine diphosphate, thromboxane A2, and the serotonin. So the third step is known as secretion. In the secretion, the activated platelet will release its granular contents, which are the ADP, thromboxane A2, and serotonin. Here we have mentioned only ADP because it is very important in the platelet aggregation. So the next step in the platelet aggregation system is the adhesion or aggregation of one platelet to another platelet in order to form a platelet plug. So what really happens that ADP, which is released from the platelet, it acts onto the platelet from where it is released, and it also acts onto the other platelets and results in the activation of platelets. So what really happens is that ADP will bind to its receptor, which is known as P2Y12 receptor, and once it binds to that receptor, it results in the increased expression of a glycoprotein, which is known as glycoprotein 2B and 3A. The glycoprotein 2B, 3A will adhere to the or connected to the nearby platelet via fibrinogen. So we can say that fibrinogen, it will bind glycoprotein 2B, 3A of one platelet, and it will be connected to the same receptor of a nearby platelet, and this result in the aggregation of the platelets. So this is the mechanism by which the platelet aggregation occurs. Now there are various clinical important points related to this slide. The first point is that whenever a glycoprotein 1b is deficient, the syndrome which usually results is known as Bernard-Sollier syndrome or Bernard-Sollier disease. In this disease, what really happens, you do not have glycoprotein 1b on the platelet, and when we don't have glycoprotein 1b, the platelet cannot adhere to the endothelium via von Willebrand factor. So this leads to functional thrombocytopenia, and on the blood smear examination, you see large platelets. The second clinical important point related to platelet aggregation system is known as Glanzmann thrombocythemia. Now in this disease, the glycoprotein 2b and 3a is deficient. As a result of this, what really happens, one platelet cannot bind to second platelet via fibrinogen. So it results in the mucocutaneous bleedings because of the defective aggregation of platelet, because platelet aggregation is very important in order to stop the bleeding, mainly in the mucosal regions which are constantly exposing to the trauma. So in the lab, when we perform the test, one platelet cannot adhere to the other platelet because of deficiency of glycoprotein 2b and 3a. Now other clinical points are related to pharmacology. So first is the aspirin. Normally we require thromboxane A2 in order to vasoconstrict, and thromboxane A2 is also a powerful aggregator of platelets. So inside the platelet, thromboxane A2 is synthesized from the arachidonic acid via an enzyme known as COX enzyme. So aspirin usually inhibits COX enzyme, and it inhibits irreversibly. As a result of this, what really happens, you have decreased production of thromboxane A2, and what are the normal functions of thromboxane A2? It causes vasoconstriction, and it is a powerful platelet aggregator. So the both events will not occur. There will be no vasoconstriction, there will be no platelet aggregation. So aspirin is antiplatelet agent. Second clinical pharmacological point is the ADP receptor antagonist, which we use in the thrombotic states like in the myocardial infarction, in the stroke. So when you inhibit the ADP receptor, ADP will not bind to its receptor, and as a result of this you have decreased expression of glycoprotein 2b and 3a. As this protein or this receptor is required for the aggregation of platelets, there will be no platelet aggregation upon the administration of ADP receptor antagonists. So we have clopidogrel, we have diclopidine. So these are the drugs which are ADP receptor antagonists. Another important point related to clinical pharmacology is the inhibition of glycoprotein 2b and 3a. So we have multiple drugs like aptifebatide, tirofiban, and apixaban which inhibit this receptor, and as a result of this we have decreased platelet aggregation. So we have disease related to platelet adhesion defect, which is Bernard-Solier syndrome, and the disease related to defective aggregation is the Klansman thrombocythemia. As well as we have two pharmacological important classes which inhibit platelet aggregation, and these are ADP receptor antagonists and the glycoprotein 2b and 3a receptor antagonists.